Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, what PulmToilet taught me about SCAPE. Now, this is going to be an interesting show. Before we jump in, real quick, I just want to mention again the spin class, the dizziness and vertigo masterclass I made with my buddy, Peter Johns. This was the work of 2 years for the two of us, and what came out of it, I think, and our beta testers agree, is an amazing course. If you have ever been confused, if you have ever been scared of patients presenting with dizziness and just hoped your colleague picked up their chart, this course will fix that. After this spin class, you will feel completely confident evaluating dizziness and vertigo patients. You will be able to diagnose posterior stroke. You will be able to discharge patients without imaging. You will be so happy. If that sounds intriguing, go to vertigocourse.com. All one word, vertigocourse.com. Check it out. You could find a sample lesson there and all of the table of contents and everything about the course. I think you will love it. All right, let's jump right in. So I was sent by, I think, 20 of you, thereabouts, a clip on Instagram from a pulmonary intensivist who goes by the handle PulmToilet. And they were like, this is upsetting. This is derogatory to emergency medicine. What the hell is he talking about? Has this guy ever treated patients with acute pulmonary edema? You know, it was all across the map in terms of how flagrant their dismissal of this clip was. So, of course, I took a listen. And, well, let me just play you the clip that I heard on Instagram.
You, maybe get butthurt, get mad. Go look at the data. Convince me that it's, number one, different than hypertensive emergency. Convince me that you have any data that supports high-dose nitro. And I'm all ears, but what you have currently is a bunch of retrospective garbage and medications where you're using them incorrectly by their pharmacodynamics. And on top of everything else, there is a real safety issue. So I'm good with whatever. If it just spurs conversation or people doing more research or looking more, that's also, I think, worthwhile. But to just sort of lump together this constellation of symptoms that we already have a name for, call it something else, and then justify giving a medication incorrectly in a massive dose that is actually potentially harmful, I think is irresponsible. Just, I don't know what else to say. So
I agree with you.
So that first voice you heard is PulmToilet, the PulmCrit Care gentleman. And the second voice is a paramedic, and he is the host of the podcast from which this clip emerged. So that full episode, I think it was about 45 minutes, was on the World's Okayest Medic podcast. And you're going to hear a bunch of clips from that podcast that then I'm going to comment on. So you have a PulmCrit guy and a paramedic, and for 45 minutes, essentially what they do is just lambast the concept of SCAPE, decry its naming unnecessary, and then talk about the treatment, specifically the high-dose nitroglycerin that we're all familiar with, as completely lacking in evidentiary base and being frankly dangerous and putting you at risk of medical legal consequences and all sorts of other stuff. And the general tone, in my opinion, and it's just my opinion, is frankly not particularly nice to the specialty of emergency medicine. And I would say, and I don't think I am being too thin-skinned here to say, an axe to grind against me personally, specifically in my coining of this term and promulgating the treatment I think we're all used to now 15 years later after EMCrit episode 1, which was actually on SCAPE, where I pushed the idea of, first of all, categorizing this condition, and second of all, treating it with high-dose nitroglycerin. So that is going to be the topic of our show today. But here's where things got a little bit strange. So after I heard the clip and listened to the podcast, I reached out to PulmToilet and said, would you come on the show? And he happily agreed. And what I was anticipating, we set the date about a week later after the invitation, was an adversarial debate based on the podcast and clips I had listened to, in which I had heard a gentleman who was not particularly kind in his debate tactics. Now, it was a debate in absentia, but nevertheless, that is what I anticipated. It's the same guy I heard on World's Okayest Medic podcast coming on the EMCrit show. And so, I prepared all of my thought processes and evidence, and then I met him on Zoom. And what I discovered is I am talking to a incredibly nice, thoughtful, respectful, easygoing, evidence-based physician. And we had a 90-minute thereabouts conversation in which at no point did he exhibit any of the behavioral tone he showed on that previous podcast. And it was a thoroughly enjoyable conversation. We both made good points, I think. I think we both saw each other's viewpoints. And now I was left with a real conundrum because, first of all, I can't square the differences in behavior. And I tried to get across that, and I'll talk about that more in a little bit. But further, I didn't know what to do with that 90-minute podcast because an adversarial podcast is very interesting for listeners like you to actually enjoy. The 90 minutes we recorded, it's the problem with these well-mannered, easygoing debates is they're kind of boring to listen to. They're very important to take part in, but they're not that intriguing for a listener. And I didn't know what to do with it. First of all, because I wanted to have the actual clips from the prior podcast in there, because even after those 90 minutes, I was still upset by the fact that that was put out into the world. I think it is a negative force in the world to put out a podcast like that. Not because of the disagreement on the medical stuff. That's fine. In fact, that's incredibly useful. That should always happen. It was just the tone and the way another specialty is spoken about and the condescending voices that were used every time they were quoting something an EM doc would say. All of that is what I'm talking about. Not the disagreement, not the debate. And so, despite an incredibly enjoyable and fruitful conversation, I still want those clips out there. And I think it would be disingenuous and mean of me to intersperse the clips I'm going to intersperse and then have what is, in my mind, a completely different interaction. Because I don't, after that conversation, I did not want to drag PulmToilet's name through the mud anymore. I wanted to still show the problems I had with the podcast that was out there, but he is a good guy. So what I figured I'd do instead is I would have my own debate in absentia. I would play the clips and then I would respond to them. And then I will send this to PulmToilet and say, man, what do you want me to do? I am open to anything. But I figured I want these clips in the world. I am not happy with the podcast that was done, even though I am quite happy with the subsequent attitude of PulmToilet. Hey folks, Future Weingart here. I sent this entire podcast to PulmToilet. He listened and he said the option he chose is let's not publish those 90 minutes. Let's let this stand as it is. And then I am going on along with him back to the Okayest Medic podcast, and we will talk about all of these issues in a post this podcast being published way. So when that comes out, I will certainly let you know by Twitter. I'll link it to this original post. So look forward to that. All right, let's first start with why we need the term SCAPE.
Sympathetic crashing acute pulmonary edema.
Remember, you're talking to cavemen and women paramedics and
big
EMTs
masturbation,
here.
Big circle jerks. So, for example, there's been a few times I picked up patients in the ICU in the morning, and we're going through the presentation like, oh, Mr. Jones is a 67-year-old man. He's from Upper Darby. He's fucking watching the Eagles. He ate a bunch of hot dogs or whatever, and now he's blah 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 blah. He has SCAPE, and I'm like, okay. SCAPE isn't real. This is not a real diagnosis. It's not in Harrison's. So we have this fake diagnosis that we've built up, and we have some shit literature to then say, let's give this medication with actual real side effects in massive doses.
All right, let's put ourselves back 16 years ago at the origin point of the term SCAPE. SCAPE stands for sympathetic or sympathetic induced when I first started talking about it, crashing acute pulmonary edema. And it was a necessary term because we were seeing this spectrum of disease in emergency medicine, and yet none of the other specialties were talking about it. And cardiology would routinely gaslight us and tell us, what we saw does not exist because they never saw it. And that is the nature of SCAPE. It is an EM presentation and it is an EMS presentation. It is not an inpatient presentation. So let's talk about what SCAPE is. This is a patient who comes in, and let's just talk about it from the emergency department perspective. And if you do not do something in the next 5 minutes, they're going to get intubated. That is the crashing part. And they are profoundly hypertensive. And the reason for their hypertension is it's not their baseline. They're not just sitting there. They are usually at a much lower blood pressure. And the reason they are sky high, usually above 180, people have put the criteria down to 160. And yeah, I guess you could see patients there, but almost always they're up above 180. And the reason why is that they have a boatload of norepi, epi, angiotensin II coursing through their system. And you know this because they are sweaty and they are peripherally clamped down. Their hands are ice cold and they look like death. They are not happy with the blood pressure they are sitting at. And that is the sympathetic part of SCAPE. So when you combine all that, acute pulmonary edema, sky-high blood pressure caused by sympathetic tone, which you know by clamped down, sweaty, poor perfusion, looking like death, the crashing part, then that is a presentation, a constellation of symptoms that puts us in a position of understanding the diagnosis and treating it in a way that is unique to the way other specialties treat milder exacerbations of heart failure. And this is the key understanding. Is they see something on the wards or in the ICU, which is a spectrum of this same disease, but not to the end stage that we see it at. And they say, we do fine. We're just putting these patients on BiPAP. We give them a few nitro. Maybe we start a nitro drip at 40. Why are you idiots treating them the way you do? You have no idea what you're doing. And it's because they don't see it at the spectrum we do. It won't happen in the hospital. Patients will start getting the beginnings of this spectrum, and then they're going to call for help because they're having trouble breathing, or someone's going to look in and see their oxygen sat has dropped to 90, or that their blood pressure is creeping up. And so they get discovered, and then they get treated well before they get to the point of SCAPE. So that's the first thing to understand. SCAPE is not a diagnosis. SCAPE is a presentation. SCAPE is a presentation of a diagnosis that all specialties see, but the spectrum of disease is fairly unique to emergency medicine and EMS. I could imagine a scenario where an inpatient doc's going to see this, but it's going to be incredibly rare. And it would be the patient on the wards that is just left to languish for hours. And for whatever reason, they can't push their call button and they get missed. But this should never be happening in a hospital. And my guess is that the nurse is going to see these patients satting 70% and call anesthesia, and they might even be intubated before people really get a chance to fully evaluate these patients, because they look at them, the patient looks like death, and they intubate them because they're sat 70%. You know, by the time the BiPAP machine gets there, it's too late. So this is a condition that anyone in emergency medicine has seen countless times. And when I say SCAPE, they know exactly what I'm talking about. They know exactly what it means. When you say SCAPE to an inpatient doc, they're like, these people are idiots. This condition doesn't exist. So that's the first problem. That's why we had to coin the term, is the cardiologists were telling us it didn't exist when we knew it did. And they were telling us to treat it in a way they would treat a mild exacerbation of acute heart failure with, some degree of hypertension, but nowhere to the degree of what we're seeing. So the reason I coined the term is because we needed a way to speak about a condition that we all were dealing with and that no one else was talking about. And so it's not in Harrison's. Doesn't surprise me at all. It probably never will be in Harrison's. Will it be in the textbooks of emergency medicine? Yeah, I'd bet a lot of money it is, because it's already in the emergency medicine literature, and it takes about 10 years from the time it hits the literature to hit the textbooks. So my guess is in the next few years, SCAPE will clearly be in the textbooks, if it's not already. I've stopped buying the newest generation of Rosen's or Titinelli, 10 years ago, because at some point, the one you have is good enough based on the fact that all of the current information comes from the internet and not from textbooks, once you've, established your foundational knowledge in a specialty. So that was why it was named. That's some of the pathophysiology. We'll go into a little bit more pathophysiology in just a bit, but let's hear more about the other names that have been suggested for SCAPE, even though SCAPE has worked very well from most people's perspective for 15 years.
And so now they're telling me it's SCAPE, and I'm like, okay, this is a fake diagnosis. It's not real. What does the patient have? And so they describe to me their symptoms. I'm like, what does that sound like? They're like, it sounds like hypertensive emergency. I'm like, it's exactly hypertensive emergency, right?
So this is one of the points we debated. PulmToilet told me we don't need the new term SCAPE. And again, I'm not quite sure why he takes such umbrage about naming something. I told him, like, look, if I had named this Weingart's disease, I could understand that there would be some trepidation and accusations of narcissism, but I don't want anything named after me. I just wanted a term that we could all use commonly in our vernacular so that there's an immediate description. And he's like, you could just use hypertensive emergency. That's what this is. It's hypertensive emergency with pulmonary edema as its symptom. Now, this is not the way I use hypertensive emergency, and this is not the way anyone in the literature uses hypertensive emergency. Hypertensive emergency is not a diagnosis. Hypertensive emergency is a collection of diagnoses. Things like acute aortic dissection, intracranial hemorrhage, acute ischemic stroke, preeclampsia, renal artery stenosis, sympathomimetic overdose. These are all hypertensive emergencies, but you wouldn't call anyone individually the diagnosis is hypertensive emergency because it wouldn't tell you which of the collection of probably 10 of them it actually is. So he's absolutely right. SCAPE is a hypertensive emergency, but it's not hypertensive emergency. Does that difference make sense? It's one of a collection of diseases that make the collective hypertensive emergency. But saying hypertensive emergency doesn't tell you pretty much anything. Otherwise, we'd be treating intracranial hemorrhage with 6 grams of magnesium because they'd all be the same, preeclampsia and intracranial hemorrhage. So it's not helpful to say we don't need the term SCAPE. It's just a hypertensive emergency. The reason we need the term SCAPE is it now joins the collection of hypertensive emergencies, and SCAPE absolutely is a hypertensive emergency. It's another differentiator from the patient whose blood pressure is 158 systolic. They have Ralls 1/3 of the way up, and they have pulmonary edema on X-ray. Well, that's clearly different than a SCAPE patient. And unless you have the word SCAPE, then you don't have a clear differentiator. You could say acute heart failure with hypertension, and you're not going to know the difference between those two patients. In fact, now that I'm thinking about it, he's basically made my point for me because most of the presentations of acute heart failure with hypertension are not hypertensive emergencies, and you treat them much more slowly and with more relaxation than SCAPE. SCAPE is different. It's a different category. It is a hypertensive emergency, and that's why we treat it much differently, much more quickly, and why we need a term to allow it to join the cadre of hypertensive emergency. Now, another one that comes up is, well, just call it flash pulmonary edema. You don't need the term SCAPE. Well, the problem with that is you could be treating cardiogenic shock the same way you treat acute pulmonary edema with sympathetic cause and a crashing nature, right? Because that also is flash pulmonary edema, but those patients are treated very, very differently. So we need a term, or I wanted a term, and everyone seemed quite happy. You see, when you coin a term, and I've seen this numerous times, I've participated in a few of them, when you coin a term and everyone's like, yeah, I don't need that term, or that term's stupid, it doesn't get used. When a term was absolutely needed, it gets taken up, and SCAPE was taken up, not because of my eminence, I don't have any as far as I'm aware, but because it was useful. All of a sudden on sign out, you say they had SCAPE, and everyone knows exactly what you're talking about. So what are you talking about? When PulmToilet's resident on rounds said the patient had SCAPE, what I would hear if I was the ICU doc was that this patient had acute systolic heart failure, they had a hypertensive emergency, and they had acute respiratory failure with hypoxia, right? That's the ICD-10. The ICD-10 coding for SCAPE is those three things. Now, you could say all that on rounds, or you could just say SCAPE. And then in both cases, people would know exactly what you're talking about. In fact, I think naming all those ICD-10 diagnoses would actually make things more difficult. It's a mouthful and people are not going to process it as well as just the one word that denotes the syndrome. So let's talk a little bit about that pathophysiology I just mentioned. So by the time a patient presents with SCAPE, they, at that stage, have acute systolic heart failure. Now, what they had before their SCAPE episode began, that's a little bit more difficult to discern in the emergency department unless the patient really knows their underlying disease. We used to think it was all systolic heart failure, or heart failure with reduced ejection fraction would be the new terminology. But subsequent studies actually show a lot of these patients are probably diastolic heart failure when they're just chilling out at home, living their life. And so that would be heart failure with preserved ejection fraction. But what happens is there's some nidus for pulmonary edema. It could be their diet, it could be medication noncompliance, it could be missing dialysis, it could be an emotional stressor. Something causes some degree of pulmonary edema. And their body's response, because they feel like they're drowning, and they're not walking around with baseline pulmonary edema, at which point there would be a blunted response. These are not the players who are having RALs at baseline. These are not the players who have peripheral edema. These patients are walking around with a heart failure that is still enough to not cause baseline symptoms. But for whatever reason, they get some degree of pulmonary edema and their body's very reactive to it, and they have a sympathetic hormonal surge, and that causes an increased afterload. And these hearts are not going to tolerate that joke of even a slight increase in their afterload. And as a result, they start getting heart failure, exacerbation, and they get more pulmonary edema, which causes more sympathetic outflow, more angiotensin II, more stress hormones, which causes more afterload increase, which causes worsening heart failure, which causes worsening pulmonary edema. And the cycle keeps going on. And they keep getting worse and worse and worse and worse to the point where they're really far gone. And that is the point of SCAPE, where they're actually crashing, where if EMS doesn't put them on BiPAP or CPAP, then they're going to buy a tube. And by the time they get to us, they have sky-high blood pressures, poor perfusion, sweaty, looking like death, and they're also going to buy a tube unless we treat them quickly. So that's the underlying pathophysiology of SCAPE.
For some reason, they do a lot of sort of like mental gymnastics for for some reason, they have some sympathetic outsurge, like some sympathetic surge, right? There's there's some substrate, like something happens. They're emotionally stressed. They are exercising. They're doing a bunch of cocaine, and they have some sympathetic burst that then causes pulmonary edema, and then it's like very specific, like hypertension and pulmonary edema, and like they're going crazy. You put them on BiPAP. You got to give them this like fuck ton of nitro, which we'll get into because it's just out of control.
So I think I explained well enough. It is not something exogenous. It's usually just their pulmonary edema is what causes the increased sympathetic tone. And then the cycle begins. You don't need to exercise. You don't need to do cocaine. It's just their pulmonary edema is enough to create the sympathetic surge. Now, as you treat it, things get interesting. Because what we were told by cardiology is throw 1 or 2 sublingual nitros underneath their tongue, put them on a low-dose nitro drip, and give them a ton of furosemide, and they get better. And those patients didn't get better. They told us they would, and they didn't. And, when I was a resident in 2003, we didn't even have the BiPAP. That came, I think, around 2004. And the treatment just didn't work. What I had seen was there were papers on, and there were randomized controlled trials of this, of isosorbide. I believe it's isosorbide dinitrate, which is a potent nitrate that causes afterload reduction in high doses. And patients with the condition I eventually called SCAPE did better than the standard treatment. And then there was a subsequent paper that said what they were using in these RCTs was the equivalent of about 600 of nitroglycerin. And I'm like, oh, that's interesting. And those papers were saying we probably could use nitroglycerin. Now, I didn't have isosorbide. I did have nitroglycerin. And when we started treating these patients, they did better. They did markedly better, like amazingly better. And As a result, high-dose nitrates and BiPAP, when it eventually came on the scene, or actually for me, CPAP, became my standard treatment for this. And then most of emergency medicine adopted it very quickly. And at this stage of the game, I would say all of emergency medicine, like an entire specialty. There's no disagreement. There's no one like PulmToilet in the EM world saying, this is dangerous, this doesn't work, this is crazy, what the hell are we doing? It's only people outside our specialty who are not treating this condition. And really, well, we'll get to whether I think specialties should talk about other specialties' care in a bit. But let's go into high-dose nitroglycerin and whether it truly is dangerous and going to get us sued, as PulmToilet would have us believe.
So what you'll see a lot in these threads is like, oh, the ED doc stands by the bedside and he makes the nitro drip like 500 and they don't leave. Like, that's not like it's cool to break protocol sometimes, but like it's just unnecessary. Like, it's unnecessary flexing that's based in just a bunch of like nonsensical stuff. I think you would tell me it's like high dose nitro and BiPAP, and then you give them a ton of nitro like to the gills, and then like you stop the pulmonary edema, and then you cure them or some bullshit, right?
So there was a lot of talk in the podcast that PulmToilet did about the fact that we don't understand pharmacodynamics if we're giving these ultra high doses of nitroglycerin. And that, first of all, it's an agent with an incredibly short half-life, and therefore you don't need a quote-unquote loading dose, and that these sky-high doses are unnecessary, that he agrees the condition that needs to be fixed here is too much afterload, but that afterload effect may start much lower, at 150 or 200 micrograms a minute. So we're crazy. We're just doing this as a flex, as he says, to give these ultra high doses. And I guess this is how he feels we get our jollies or something. I'm not sure. That's not it. And so you have to understand a little bit more about the pathophysiology. So when they're at that crashing stage and their heart is barely doing anything because the afterload's like a stone wall it can't pump against, if you even for a minute or two get the afterload low enough that their heart could get back to its intrinsic level of function, their pulmonary edema starts clearing massively within a very brief amount of time. And if, on the other hand, you give them some afterload reduction, but it's not enough to allow that heart to start pumping with good function, they maintain the same level of pulmonary edema. I mean, maybe it gets a little bit better, but they're still drowning. So they still have their endogenous sympathetic tone there. So if you're not making them much, much better, they are, in essence, getting worse is the problem. So putting them on the beginning afterload reduction dose of nitrates doesn't really do much. And we've discovered that. What you need to do instead is open them up rapidly, and then they get markedly better. And it's led me to conceptualize that SCAPE really has 3 phases of treatment. There's the crashing phase, and if you do it right, the crashing phase could be 3 minutes, 5 minutes. And you've all had this experience if you're an emergency doc listening to this, and you've probably never had this experience as a critical care doc. But you'll take these patients, they look like death, they like look like if we don't tube them, they're going to die. And you give them whatever dose it takes to get a big afterload reduction, and then they're better 3 minutes later. They're smiling. They're on the BiPAP. You ask them how they're doing. They give you a big thumbs up. They stop sweating. Their hands are perfusing. They're warm. And it's an entirely different patient. And they're not done yet, right? We don't turn off everything and they win. So that's the second phase. They go from crashing in the first phase to just sick in the second phase. And the just sick second phase is where most of the inpatient docs see this condition. And that's why they think we're crazy to do what we're doing with those incredibly high doses up front. Because at this stage of the game, after you've given 800 micrograms of nitro, a milligram of nitro, maybe you repeated it. So a milligram, wait 3 minutes, and another milligram of nitro. And then they've gotten past that crashing stage. And in the sick stage, you don't put them on a milligram of nitro a minute. You would never use high doses like that continuously. In fact, my protocol when episode 1 came out was 400 micrograms for 2 minutes. So an 800 microgram load over 2 minutes, and then drop them down to 100 or 150 and see where they sit. And so if you gave a milligram of nitro, you're starting at that 100 or 150 because they're out of that crashing phase just from that one big hit. They've massively reduced their pulmonary edema. They are perfusing. They look better. They're still sick. You leave them on that drip for some period of time. Usually it's like 45 minutes, an hour. And then they go from sick to well. They're back to their baseline function. And the problem is they never drop their blood pressure, at least in my hands. I've never had one of these in 16 years where they drop their blood pressure during the... Okay, folks, that abrupt ending is because you've reached the end of the free version of this podcast. There's another 30 minutes of discussion on this, and you're reaching that because you're not a member of EMCrit, but you should be because it's inexpensive. You get continuing medical education. You get a host of other things you're not getting in the free version. You're getting the RAC, the Resuscitation and Acute Critical Care Literature Review. You're getting podcasts that are the ones I've been told are people's favorite on EMCrit, which, most of the interviews go up as foam for a while when they're first published. Most of these single just me episodes I actually release just to my members. And the reason I do that is the interview ones, you're helping out someone else's career. The person I'm interviewing, it benefits them to have their voice and ideas out in the world. So that's why generally I don't like to make those behind a paywall. But the ones of just me, I got no problem. I don't need any career advancement. I am quite happy to not have my voice any further than the people who are willing to commit to be members. So please consider it. Obviously, if you can't afford it, you probably should get in touch with us because we could help you with that. But if it's just you don't like it, you don't want to pay money for it, no worries, understood. Just keep going for the free stuff. But if you want to join, emcrit.org/join. That address again, emcrit.org/join. Bye.